Primary central nervous system lymphoma is an aggressive malignancy which affects patients with a median age of 60-65 years. Usually patients at presentation are a very symptomatic disease with a poor performance status and a clear neurological impairment. The results of the prospective trials in the last decades were significantly improvement due to a wider international cooperation. A modern approach to the patients with primary CNS lymphomas include two different phases, an induction phase and a consolidative phase. The induction phase is include different strategies, two in particular: the high-dose methotrexate-based chemotherapy and the Wolverine radiation therapy, the latter for patients who are not able to tolerate combined chemotherapy. In the last year, some others suggested that methotrexate can be challenged and replaced by other combinations, in particular those including high-dose ifosfamide. The therapeutic choice for the induction is based on the age and performance status of the patients, but also on comorbidity and prognostic factors. The choice of the consolidation phase is based on the tolerability response and quality response to the induction treatment. And there are several available strategies: the maintenance, the autologous stem cell transplantation, the Wolverine radiation therapy, and the non-myeloablative chemotherapy. In the last years, we reported the results of the randomized phase 2 trial, which included 219 patients treated at 53 centers in 5 European countries. In this trial, patients with primary CNS lymphomas up to 65 years old with a performance status up to 3 or up to 70 years old with a performance status up to 2 were randomly allocated among conventional methotrexate-cytarabine combination or the same combination plus 2 doses of rituximab or the same chemoimmunotherapy plus tiotepa. The patient received 4 courses of this treatment, and according to the response, they were randomly allocated between conventional radiation therapy or autologous stem cell transplantation conditioned by a BCNU tiotepa combination. The results of the trial show that the combination of the 4 drugs, methotrexate, cytarabine, tiotepa, and rituximab, that is the matrix regimen, was associated with a significantly improved progression-free survival and overall survival with respect to the other 2 arms. And this is the new standard chemotherapy induction for patients up to 70 years old. Regarding consolidation, both strategies showed a similar high activity and efficacy, and both strategies can be suggested to our patients. However, patients treated with consolidative radiation therapy showed more commonly an impairment in some cognitive functions, in particular attention and executive functions. Conversely, patients treated with autologous stem cell transplantation showed an improved functions and improved quality of life. Then our suggestion is that patients up to 70 years old should be treated with matrix combination plus autologous stem cell transplantation. For elderly patients or patients who are not able to tolerate this treatment, other combinations, including high-dose methotrexate, an alkylating agent, and rituximab, are suggested. And in the last year, there are some growing evidence supporting the role of maintenance with oral alkylating drugs or with lenalidomide, an immunomodulator. This strategy produced the encouraging result in the Nordic trial. Obviously, there is a lot of work that we will be performed in the next years. The next trials will be focused on challenging high-dose methotrexate to improve the efficacy of the chemotherapy with the use of new target therapies or with the new monoclonal antibodies, but also changing the overall strategy, perhaps intensifying the treatment following an early assessment of the response.